Good morning, everyone. Today we convene the first hearing of the Subcommittee on Oversight and Investigation in the 113th Congress. I'd like to welcome back the members who served here in the 112th and welcome our new members joining us for the 113th. I want to particularly welcome my colleague and my friend, the Ranking Member Diana DeGette of Colorado. I'm looking forward to working with you and your team here. And this is the first of many hearings and issues that we'll be dealing with in an organized bipartisan way, and I appreciate the witnesses for coming here today. Today we are here to examine the current flu season and discuss the lessons that will help us prepare for seasonal influenza and pandemics in the future. This committee has investigated into response efforts during previous sessions, last during the H1N1 pandemic in 2009, and oversight of the agencies involved will remain a priority going forward. I welcome our distinguished witnesses whose agencies play key roles in the federal government's response to influenza. Dr. Thomas Frieden, Director of the Centers for Disease Control Prevention, welcome here today. Dr. Jesse Goodman, Chief Scientist at the Food and Drug Administration, welcome here, Doctor. And also thank Marcia Cross, Director of the Health Care Division of the Government Accountability Office. Welcome here as well, Doctor, for being here. The GAO has done a number of reports analyzing federal response to seasonal and pandemic outbreaks. Well, this year's flu season came a little earlier than expected, and it looks as though it will have been, unfortunately, worse than average. This is particularly true in my home of southwestern Pennsylvania, which has the highest percentage of seniors in the country outside of Florida. In the Pittsburgh region, for one, this year's flu season has been labeled a nightmare. At local nursing homes that have taken to restricting visitors and quarantining sick patients. For seniors in southwestern Pennsylvania and across the country, hospitalization rates and deaths have increased sharply, and sadly this season has also taken its toll on the most vulnerable. Through February 2nd, there have been 59 pediatric deaths. Today, I hope to hear how the CDC, the FDA, and the vaccine manufacturers are working together through development of new medications, better surveillance to prevent shortages, and increase vaccination to protect the public from deadly flu viruses. Remember, all of us should consider vaccination to not only protect ourselves from getting sick, but also our children, grandparents, coworkers, and neighbors. The CDC recommends annual vaccinations for all persons aged 6 months or older, yet less than 50% of Americans actually got immunized. Today, I hope to learn what the biggest barriers are to people getting vaccinated and how we can remove them. Each year, a new vaccine is produced and administered to protect against the strains expected to be most prevalent that year. But because of the increased activity this season, many have wondered about the process that creates this seasonal vaccine and whether it can be improved. Questions have also been raised about vaccine effectiveness. We've heard from government representatives that this year's vaccine has an effectiveness rate of 62%, meaning that someone who is vaccinated is 62% less likely to see a doctor for the flu than someone who hasn't been vaccinated. To some, this might seem low, but we have heard that this is actually within the range of what is expected. How can we improve upon that, and what efforts are currently underway in the government and the private sector to ensure that we do? This year, we've also heard reports of spot shortages of vaccine and certain antiviral treatments, yet we know that overall vaccine and antiviral supply will still exceed demand. What role did the federal government play, along with its public health partners at the state and local level, in responding to these supply issues, and what can we learn from these efforts going forward? Finally, I wish to again thank Ranking Member of the committee, Ms. DeGette. This hearing has been a bipartisan effort, and the Ranking Member and I have been working together on a number of issues. I thank her for her support on this and other issues as we move forward. As well, I'd also like to thank the witnesses. As I said before, and I have time to meet with the representatives from CDC and staff, also reports to me that all your agencies have been more than helpful in addressing their concerns, so thank you in preparation for these complex issues. And with that, I will now recognize Ranking Member DeGette for her opening statement for 5 minutes.
Thank you very much, Mr. Chairman, and welcome, Ms. Chairman. We're delighted to have you, and the Chairman is correct. We've been working quite closely together ever since his appointment on issues that are facing this committee. And given the Energy and Commerce Committee's broad jurisdiction, really the world is our jurisdiction on this subcommittee. Mr. Dingell and I think even Mr. Barton would agree this is probably one of the most venerable and important committees in the U.S. House of Representatives, and I look forward to working very hard with you, Mr. Chairman, and the rest of the committee to making sure that, that we have very thorough and important investigative hearings. Flu preparedness is one of those issues. This committee has had a number of hearings over the years on preparedness, not just for the next flu season, but also in the event, which we hope will never happen, of a pandemic. And I'm glad that you have scheduled this first oversight hearing on this issue, because it's one that the committee has had a concern about for many years. According to the CDC, this was a bad flu season. The worst of it is now nearing its end, and fortunately this flu season did not reach pandemic proportions. The other, if you can find good news in this flu season, it has been a good demonstration of the public health system operating as it should. The FDA worked closely with manufacturers to ensure adequate vaccine supply, and the CDC collaborated with the states in its surveillance and tracking efforts. When the season peaked in January, CDC got the word out, and many people who had delayed were still able to get vaccinated. Now, while we saw spot shortages of vaccine and antiviral drugs in certain areas of the country, unlike previous seasons, we didn't have any serious shortages. But I must say the threat of influenza is one that we cannot underestimate, given its potential impact on the nation and the world's public health, security, and economy. Vaccination rates are one area in particular where we can make significant progress. The latest data from November shows that only 36.5% above those who were 6-month-old got vaccinated. The most important step in protecting against the flu is to get a flu shot. So I'm interested in hearing from the witnesses how we can improve our vaccination rates. The Affordable Care Act is going to be one way to improve flu prevention and care. Because of this act, 54 million Americans can now receive a free flu shot through their private health care plan. And next year, CBO estimates that 14 million Americans who would otherwise be uninsured will instead have health care coverage. That number will increase to 27 million by 2017. Each flu season is a practice run for how well we would do in a pandemic. After the H1N1 pandemic in 2009, it became really apparent that we would need more vaccine alternatives to deal with potential shortages. We need to be able to make vaccines faster and to make them more effective against the flu. And that's why I'm excited to see that the FDA has approved numerous alternative vaccine technologies that hold the potential for faster startup of the manufacturing process in the event of a pandemic. These new approvals provide alternatives to our current decades-old use of time-intensive egg-based technology to produce vaccines. In the event of a pandemic, egg-based production would be too slow to meet heightened demand for vaccine, with the potential loss of millions of lives around the world. In November, the FDA approved the first seasonal flu vaccine using cell-based technology. With cell-based technology, the virus strains are grown in animal cells instead of eggs. This is a huge step forward in expanding vaccine supply. And last February, FDA approved FluMist, the first vaccine to protect against 4 rather than 3 strains of the flu. By improving protection against the flu, these new quadrivalent vaccines will protect millions of Americans. Mr. Chairman, these are great examples of laudable government investment. But beginning in 2005, HHS recognized the gap in the public health system and subsequently made investments to deal with this. And that's truly a government success story. While I'm encouraged by the fact that these alternative technologies have come to fruition, we have a long way to go. We must remain vigilant against the risks of a flu pandemic. Pandemics are infrequent, highly unpredictable, and come on suddenly. And so we have to have constant vigilance. I appreciate our witnesses coming here today. I'm eager to hear what they have to say about the progress that we've made and the state of vaccine innovations and improvements, because frankly we must do whatever we can to make sure that we have better flu preparedness. Thank you, and I yield back.
I appreciate the gentlelady's comments, and I now recognize the chairman of the full committee, the gentleman from Michigan, Mr.
Well, thank you, Mr. Chairman, and welcome to your first chairmanship of the Oversight Subcommittee here in the Big House. I want to welcome you to that. I had the opportunity, as you know, to chair this subcommittee a number of years ago, so I know firsthand the important work that can be done from that post. Oversight has a number of very, very important purposes, but one of the most significant is ensuring that our federal programs are working properly and efficiently, especially in matters relating to public health and safety. And it's often a bipartisan role, and I appreciate the role that your ranking member has as well, Ms. DeGette. With regard to the flu, this committee examined the response to the H1N1 pandemic 3 years ago, and it probed influenza vaccine shortages in 2004. We have a tradition of doing strong oversight in this area, and we are well aware that this has been a very tough flu season, and we have been especially troubled by this season's particularly harmful impact on the elderly and kids too. We've also heard reports of spot shortages, especially in hard-hit areas, and questions about the effectiveness of this year's vaccine. The good news is that while outbreaks appear to be on the decline overall, parts of the country are experiencing increases, so it remains important to hear the most up-to-date facts and figures on the current season and examine what the government is doing to prepare for future seasons as well as pandemics. Personally, some of what I've heard from my neighbors in Michigan about this year's flu is similar to what we've seen in the national press. Lakeland Healthcare, which provides care in my hometown, reported to my office that while they did not have a shortage of vaccine, they had to help supplement their supplies with other healthcare providers. I'm pleased that whenever I hear that providers are communicating with each other to address these issues at the local level, but remain concerned about whether there is enough supplies available in the next outbreak. While we're still evaluating the responses to the flu season, we need to be prepared for the possibility of a worse outbreak or even a pandemic in the future. I'm excited about the recent innovations in vaccine technology and the role that they play, and I welcome our witnesses, and I yield the balance of my time to Dr. Burgess.
I thank the Chairman for the recognition. I thank our witnesses for being here today. We've heard already that this flu season was one of the worst that the United States has experienced in several years. It began early and was particularly harsh. It's most often thought to affect infants and the elderly. But as we saw many times in this outbreak, all age groups are susceptible to infection and the complications of a flu infection. You know, talking about the statistics is one thing, but I will tell you from firsthand experience, when you lose a vibrant 17-year-old member of the golf team from one of your high schools in your hometown over the Christmas holidays, it has a profound effect on the entire community. Max Schwolert was that individual from Flower Mound, Texas, actually became ill while on holiday with his family up in Wisconsin and Minnesota, but ultimately became ill at Christmas and succumbed by December 29th to a staph infection that was superimposed on his influenza. His dad is a youth minister at Faith Lutheran Church, and obviously a very high visibility family within the community, and certainly took its toll on members of the community. They have done good work since that time in encouraging the vaccination, and as we've already heard this morning, the vaccination was available this year, was perhaps a little bit better, so thank you for your efforts on that to develop a better vaccine. It doesn't protect everyone in every instance, but it certainly improves the odds. And as we saw in this unfortunate case, being young and healthy does not always confer the immunity that we think it should. We've got a lot to learn yet about the future of vaccination. And while I recall the enthusiasm of the cell-based cultures in 2005 and in the enthusiasm for finding a vaccine that didn't have to be changed every year, we're now 8 years later, and I do have some questions about when those things will be coming online. The flu season is almost done, not quite done. The overall effectiveness of the vaccine this year was good to better than we might have expected, and the preparedness was something that certainly is laudable. So I'm grateful to all our witnesses for being here today. We do have a big task ahead of us, and we need to keep vigilant. Now I'll yield back.
I thank the gentleman from Texas. I'd now like to introduce the witnesses testifying today. First, Dr. Thomas Frieden, the Director of the Center for Disease Control and Prevention. Dr. Frieden was appointed in 2009 and also serves as the administrator for the Agency of Toxic Substances and Disease Registry. Dr. Jesse Goodman is the Chief Scientist for the Food and Drug Administration. Dr. Goodman has served in that position since 2009 and has previously testified before the Subcommittee on Influenza Preparedness. Thank you. And Marcia Cross. Dr. Marcia Cross is Director of the Government Accountability Office Healthcare Team. Dr. Cross is responsible for overseeing GAO evaluations in the areas of biomedical research, bioterrorism, disease surveillance, and other health issues. You're all aware that the committee is holding an investigative hearing, and when doing so has the practice of taking testimony under oath. Do you have any objections to testifying under oath, any of you? Okay. Seeing no objections, say the chair then advise you that under the rules of the House and the rules of the committee, you're entitled to be advised by counsel. Do you desire to be advised by counsel during your testimony today? The panel answers no. The chairman, as chairman, I say in that case, would you please rise and raise your right hand, and I'll swear you in. And do you testify that the testimony you're about to give is the truth, the whole truth, and nothing but the truth? Everyone answers in affirmative. And since you are now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code, you may now give a 5-minute summary of your written statement. So we'll start off with Dr. Frieden. Dr. Frieden, you're recognized for 5 minutes.
Thank you very much, Mr. Chairman and members of the subcommittee. I'm Dr. Tom Frieden, Director of the Centers for Disease Control and Prevention, and I appreciate this opportunity to share with you the latest information about influenza. I think there are 4 basic bottom line issues here. First, flu is a deadly and costly disease. Second, this year's season has been worse than average and particularly severe for the elderly. Third, we're making progress applying the best tools, vaccine and treatment, that we have. But fourth, we still do need better tools, and we're making some progress in that area. Every year in the United States, on average, between 5 and 20% of all Americans get influenza. That results in tens of millions of cases, more than 200,000 hospitalizations, more than $10 billion in healthcare, $10 billion, in direct medical costs, and over $80 billion in societal costs, including an estimated 17 million lost workdays, many of which could be prevented by vaccination. Flu seasons are unpredictable and they can be severe. We estimate that in recent decades, between 3,000 and 49,000 people have died each year from influenza. The 1918 pandemic killed more than 50 million people around the world. And of all of the infectious diseases that occur in nature, influenza remains the one that results in those of us who work in public health losing the most sleep. This year's flu season began early, and for most of the country, the 2012-13 season has already peaked and begun to decline, but there's still many cases around the country, and it's likely that flu activity will continue for several weeks. I'd like to just show a series of slides that shows the spread of influenza through the country. You can see it emerging in the south, southeast, spreading throughout the country till virtually the entire country was seeing relatively high rates. So we've seen a relatively hard-hitting flu season this year. The predominant virus is H3N2, which tends to cause more severe illness among the elderly. And the next slide shows the hospitalization rate among the elderly. And what you can see is that it's about twice as high this year as in previous years. And this is for laboratory-confirmed influenza hospitalization. Although it's far from perfect, flu vaccination is by far the best tool we have to fight the flu. Unfortunately, it is not as effective as we would like and is less effective for the elderly, particularly the frail elderly. Vaccination of healthcare workers and children not only protects these individuals, but also appears to benefit the community. Despite some spot shortages late in the season, there was a good supply of vaccine this year with about 145 million doses and about 40% uptake. Individuals who have underlying health conditions only had a 42% flu vaccination rate, so we really need to do better for particularly the higher risk populations. We can all reduce flu by staying home, when we have a cough and covering coughs and sneezes. And importantly, for people who are under 2 or over 65 or have underlying health conditions, getting seen promptly and treated can reduce the severity of influenza. Flu is also a great example of global collaboration. 110 countries track the spread of flu, and we have staff around the world who work with countries because if they identify it sooner, it helps us to identify what we should put in the vaccine and what we can do to reduce the burden of flu here. We have a unique role in monitoring and providing recommendations and guidance and supporting state and other partners, but we also work very closely with other federal agencies, including FDA, NIH, and BARDA, to ensure an adequate and safe supply of vaccine. There's a great example of collaboration between federal, state, and local levels through the 317 and the VFC programs, and with the private sector for manufacturing, distribution, treatment, with healthcare systems that protect their patients by increasing healthcare worker vaccination. Looking to the future, I think we can see improvements in technology. In manufacturing, some progress is being made. FDA, BARDA, NIH, and private manufacturers are coming up with new products. You could describe these as important and useful tweaks, but yet no breakthroughs in terms of a better, longer-lasting, more effective vaccine. One of the tweaks has been a potency assay to speed up the process of producing flu by about a month through work of CDC scientists that is now being rolled out in collaboration with the FDA. We've also increasingly been unleashing the genomic revolution to come up with faster growing and more effective strains that we provide to the manufacturers. We're also looking at the next generation of diagnostics that use the genomic revolution again to identify strains more rapidly. Flu emphasizes that we're all connected by the air we breathe, and the emergence or spread of flu anywhere in the world is a potential risk anywhere else in the world. In conclusion, there's light at the end of this year's flu season tunnel, but many are still at risk. At this point, prompt treatment of those at high risk is key to reducing illness and death. We're already tracking flu strains in the southern hemisphere as we head toward developing a vaccine for next year's flu season, and we continue to build on our global capacity to find and stop new pandemic threats where and when they emerge, rather than waiting for them to reach our shores. Thank you, and I look forward to answering your questions.
Thank you, Dr. Frieden. Dr. Goodman, you're recognized for 5 minutes.
Thank you. Mr. Chairman and members of the subcommittee, I'm Jesse Goodman, Chief Scientist at the FDA and also practicing infectious disease physician. I appreciate the opportunity to be here today and talk about FDA's role in protecting the public from influenza. Flu seasons are quite unpredictable, and this year's season is a very telling reminder of how seriously we have to take flu. As Dr. Burgess pointed out, I too have seen or heard of instances where even very healthy young people can be struck down by this disease. So people tend to think of this as a cold or something, but most things that are colds are not influenza, and most influenza can be quite severe and kill even healthy young people. Our basic message is, while this is a major public health problem we need to pay attention to, we've also made tremendous progress. To meet the threat of flu and other infectious diseases, we work very closely with our partners throughout the government in what we call the Public Health and Emergency Medical Countermeasures Enterprise, which includes numerous HHS partners as well as DOD, the VA, the USDA, et cetera, and the DHHS Assistant Secretary for Preparedness and Response. This year, in response to this flu outbreak, we've expeditiously approved and lot released all available vaccines from 6 different manufacturers. And as Dr. Frieden said, this, and as reflected in the GAO report, this 140 million doses is a dramatic improvement from where we were a few years ago. We also helped avert shortages of antiviral medicines such as Tamiflu. We authorized the rapid release of 2 million doses in a manufacturer's stockpile. We've also worked with the manufacturer and CDC so that pharmacists could use capsules to make liquid Tamiflu needed to treat small children, and that's been very helpful. Unfortunately, every time we have a bad flu season, there's a bunch of unscrupulous people who come out of the woodwork with fraudulent flu products and try to take advantage of the public. So we have heightened our FDA surveillance of these various scams, including looking at websites. We've taken action where needed, and we've actually put information out to the public about fraudulent flu products that includes red flags they should look for in assessing these kinds of claims. Now, with respect to vaccines, FDA doesn't make vaccines, but with influenza vaccine, we have a very unique and intimate role working with numerous partners to get the job done every year. Vaccine preparation is a very intensive, year-round, coordinated response involving working closely with the manufacturers on almost a daily basis, as well as with our global public health partners, WHO, CDC, and others. It has numerous steps I won't go through here based on time, and manufacturers exhaustively test their vaccines and submit results and samples to FDA. Now, why are we here in part is because of this virus. This is a unique virus. It's constantly changing. It's a crafty and unpredictable virus, and the surface proteins on the virus are changing all the time, and that helps it evade our immune systems, and it also helps it evade our vaccines, which is part of the challenge there. 10 years ago, we had only 3 U.S. licensed influenza vaccine manufacturers. We initiated significant efforts, including a new accelerated approval pathway to increase the diversity amount of vaccine supply, as well as to upgrade manufacturing quality and hopefully do all we can to prevent failures in manufacturing. And as a result, we now have 7 manufacturers and an approximate doubling of supply. In addition, I would say as a result of substantial ASPR, BARDA, and industry investment and very intense interactions with FDA, as you've heard, we have 2 recent innovative flu vaccine approvals. The first is Flucelvax, made by Novartis, the first U.S. licensed cell-based flu vaccine. Advantages of a cell-based vaccine include elimination of the need of a large number of fertile eggs, which can be a problem if there were an avian flu outbreak, better growth of strains that sometimes grow poorly in eggs, and faster startup and scale of manufacturing. Also good news is that Novartis is planning to manufacture this in their new facility at Holly Springs, North Carolina, that was built with a lot of ASPR BARDA support as well, and will substantially increase U.S. manufacturing capacity. The other new vaccine is Flublok, manufactured by Protein Sciences, again developed with government support, and it's the first using recombinant DNA technology. This is produced using an insect virus grown in insect cells to produce the flu virus protein. It can be manufactured just based on the genetic sequence of the virus. You don't need a living virus at all, and this can therefore be obtained within days instead of weeks. And in a time-limited situation like a pandemic, this could be very advantageous. We've also worked with BARDA to retrofit existing manufacturing facilities to increase their surge capacity. And recently, FDA is working with BARDA in a collaborative way to provide technical assistance in 3 very exciting, recently funded centers called Centers for Advanced Innovation and Advanced Development and Manufacturing, located in Texas, North Carolina, and Maryland. But you've heard about the need for more effective flu vaccines, and this is also a high priority. I just want to say a word about that. There are a number of promising approaches under active research and development. They're not here today, but we're hoping to get there. These include efforts to induce a stronger, more effective, longer-lasting immune response that could protect against viruses that change over time. And there are efforts going on directing vaccines against recently identified parts of the virus's genes that are conserved among multiple strains as another strategy. Another thing we're doing is trying to improve diagnostics. Accurate diagnostics are incredibly important. They can avoid unneeded use of antivirals and antibiotics. And as well, we're trying to facilitate development and use of the antiviral drugs. So in conclusion, we've come a long way in enhancing our ability to prepare for and respond to influenza. We're fully engaged in an ongoing intensive effort to enhance our nation's preparedness. We're much better prepared. There have been several landmark recent approvals, and there's developing new science that promises a bright future. I did want to mention that the response to influenza is every single year a remarkable public-private partnership. We're all working together, and I'm optimistic that the gains have been made are on track to continue. Thank you very much.
Thank you, Dr. Goodman. Dr. Cross, you're recognized for 5 minutes.
Thank you. Chairman Murphy, Ranking Member DeGette, and members of the subcommittee. I'm pleased to be here today as you examine issues related to the current influenza season and influenza preparedness. As we've already heard, this season there has been early and intense influenza activity throughout much of the country with some spot shortages of vaccine. My remarks today focus on lessons learned from federal responses to prior influenza outbreaks and federal investments to strengthen the U.S. vaccine supply. My testimony is based on multiple GAO reports on seasonal and pandemic influenza. Our prior work has identified a number of lessons from the response to seasonal vaccine shortages and the 2009 H1N1 pandemic and actions the government has taken to improve the vaccine supply. The primary lessons we observed can be grouped into four broad interrelated categories: the value of planning, the importance of effective communication, the difficulties in predicting the predominant influenza virus strains that will be circulating in a given season, and the challenge of matching available vaccine supply with public demand. First, planning is critical to an effective response. For example, planning activities conducted prior to the H1N1 pandemic, such as exercises and interagency meetings, built relationships among federal, state, and local governments and positioned them to respond effectively. This type of planning is especially important in years when there are vaccine shortages or when there are specific groups for which vaccine must be prioritized. Second, clear and consistent communication is key, especially regarding the availability of vaccine. The failure to effectively manage public expectations of vaccine availability can undermine government credibility and contribute to individuals' failure to seek vaccination. This has been a problem in years when vaccine is in short supply or is delivered later than anticipated, but it can even be a problem in years with no shortage, such as this year, if individuals are uncertain of when or where to obtain vaccine. Third, predicting the influenza virus strains that will predominate in a given season and their likely severity is difficult. Because the selection of the 3 viral strains normally included in the vaccine is typically made in February, in some years the vaccine may not be well matched to all the strains that are circulating during the following winter. A positive development is that FDA recently approved 2 new vaccines that each protect against a total of 4 influenza strains, 1 more strain than traditional seasonal vaccines. These new vaccines are expected to be available for the next influenza season. And fourth, matching influenza vaccine supply to demand is challenging. Because of the lengthy production cycle, manufacturers make production decisions months in advance of a seasonal outbreak, and vaccine supply orders are generally placed before providers know what the severity of the outbreak will be. Manufacturers may be reluctant to produce, and providers may be reluctant to order vaccine that exceeds their projected demand because if the product is not used by the end of the season, it must be destroyed. Over the last decade, HHS has taken steps to strengthen the influenza vaccine supply by making investments in the development of alternative vaccine production technologies and by enhancing domestic production capacity. Since 2005, HHS has awarded over $1 billion in contracts to manufacturers to develop new influenza vaccines that rely on cell-based or recombinant technologies. And 2 of these alternative vaccines are expected to be available for the next influenza season. In summary, over the last decade, progress has been made in the federal government's preparation for and response to both seasonal and pandemic influenza events. Planning activities have helped with response efforts. Communication with the public regarding where and when to get vaccine has been clearer and more effective, and manufacturers have been encouraged to enhance domestic production capacity and develop alternative production technologies. Yet, the fact remains that when facing a typical influenza season, manufacturers must make decisions about how much vaccine to produce, providers must determine how much vaccine to order, and individuals who may be influenced by a particular season's perceived severity and media reports must make their own decisions about whether, when, and where to seek vaccination. These factors, along with challenges inherent in the vaccine production process and influenza seasons that are unpredictable in terms of duration and severity, can still present barriers to successfully making vaccine available when and where it is needed. Mr. Chairman, this concludes my prepared remarks. I'd be happy to answer any questions that you or other members of the subcommittee may have.
Thank you, Dr. Cross, and thank you all the panelists here for today. Every member will have 5 minutes to ask some questions. At this point, the chair recognizes himself for 5 minutes. Dr. Frieden, the Center for Disease Control recommends every American over the age of 6 months gets a vaccine. I believe it's less than 50% of Americans actually get immunized. First of all, what's the optimal percentage that you hope for for example, the herd effect on things of people to get immunized?
We like to see at least 80% vaccination rates, and obviously higher is better.
So why aren't more people getting vaccinated? Why this big gap?
What we find is that the easier you make it for people, the more likely they are to be vaccinated. One encouraging trend in recent years is that an increasing proportion of all vaccinations are being given in workplaces and in pharmacies. In fact, more than a third of vaccines so far this season have been given in either of those settings for adults. We also find that the healthcare system can make a big difference. So things like standing orders or routinely providing it to all people who come into emergency departments, having subspecialists who see patients also recommend vaccination and arrange it either at a pharmacy or elsewhere, standing orders, reducing barriers, eliminating cost sharing, which is something that is expanding to the private insurance market through some of the provisions of the Affordable Care Act, and also education. Hearings like this, community outreach, public education, all makes a difference. What we found this year as an example is in the one group, pregnant women, we've looked very closely at. And what we find is that if the obstetrician actually provides flu vaccine in the office, we have about a 75% vaccination rate among pregnant women, whereas overall it's at about 50%. That's actually a big increase from previous years. There was a bump during the 2009-2010 pandemic, and that's been sustained. The second group that we've looked at closely is healthcare workers, because when someone is vaccinated, they not only protect themselves, they protect those who they have contact with. And we know that there is some evidence that suggests that low vaccination in healthcare workers in nursing homes in particular can have very severe ramifications. What we find is that pharmacists, nurses, and doctors have vaccination rates of 80 to 90%, so quite good, but that allied health workers and people who work in nursing homes may be under 50%. So we've identified the areas where we need to reach out more. Bottom line is fewer barriers, more convenience makes a big difference.
I'm just curious, to just say that about the barriers with cost sharing. Have you done any follow-up studies on, for example, you mentioned a pharmacy or somewhere else might provide these vaccines? I mean, I've seen some for free, some for extremely low cost. Have you done any correlational studies to help understand that part?
I'm not familiar whether we've done this in influenza. This has been looked at in a variety of programs, and it's pretty consistent that cost sharing reduces utilization, but we can get back to you to see if that's been looked at in influenza specifically.
And just a quick myth check. When a pregnant woman gets a vaccine, is that any risk to her child?
No, there's not. We recommend the inactivated vaccine for pregnant women rather than the live attenuated vaccine.
Thank you. Now we know it's been particularly hard on seniors. So Dr. Frieden, Dr. Goodman, why has this been the case for seniors this year?
H3, for reasons that we don't fully understand, years that are H3 predominant, and this season is overwhelmingly H3 predominant, tend to be more severe among the elderly. There are various theories for that, but bottom line is we're not sure why. It's something that we see in 2003, 2004, as well as 2000, 2007, 2008. Those were our two prior H3 predominant seasons, and similarly, in those years, the disease was more severe among the elderly. That's one of the reasons we try to vaccinate around the elderly so that we can reduce spread in the population, and we encourage prompt treatment because treatment, particularly in the first 48 hours, can improve outcomes.
Dr. Goodman, let me add a little part to that too. Can you speak to any, or you or Dr. Cross, any recent innovations in vaccine technology that can lead to more effectiveness for seniors?
Yeah. Well, I think this is the big challenge, and part of the challenge is inherently related to the answer to your last question to Dr. Frieden, which is that we don't respond that well even to the virus itself, which is why we get so sick and why so many infections end up doing badly. So part of the problem is that when you give the same material that's in the virus in the vaccine, we don't always respond that well to that either. There are a number of approaches being taken to potentially enhance the immune response. And most of these are in the research and development stage. Some are being supported through HHS and NIH funding. For example, if you package the proteins of the virus in a particle that appears or the immune system sees as a virus, sometimes called a virus-like particle, that can sometimes induce a stronger immune response. The use of adjuvants or substances that boost the immune response can give a stronger immune response. So these things are all being examined, and they need thorough examination for safety and effectiveness. There are also parts of the virus that have been discovered recently, for example, something called the stalk, that is part of the protein we immunize against, but it's not normally in the vaccine. But it seems to be conserved year after year in multiple isolates. So if we could induce a good immune response against that, it would help. I want to take one opportunity to follow up, add to Tom's response on your comment about pregnancy.
If you do that quickly, I'm out of time.
Yeah, because I think one of the ways we increase uptake of vaccine is for people to understand the science. And there was recently published a study in Norway that showed in 115,000 women who received influenza vaccine that actually their fetal outcomes were, if anything, better than people who hadn't received vaccine, and a significant reduction in influenza disease associated with vaccine use. So the science is there to support the safety of the vaccine in pregnant women.
Thank you. I'm out of time. I'll now recognize Ms. DeGette for 5 minutes.
Thank you very much, Mr. Chairman. Dr. Cross, first of all, to the panel, this is encouraging news, and I'm glad to hear it after the number of hearings we've had. Dr. Cross, you talked about a number of advancements that we've made and also the challenges that we're facing. I'm wondering if you can just briefly tell me about intergovernmental cooperation in identifying potential pandemics and communication. Has that also improved?
That has improved. CDC's global surveillance has improved significantly in the last decade, and as we know, many of these strains emerged somewhere else in the world. In fact, people were surprised that the H1N1 emerged in North America.
But it has that communication.
It has improved. We are across the board. We are in much better shape than we were 10 or 12 years ago.
That's great.
There's still room for improvement.
Sure. And what about surge capacity? That was the other thing we've always been concerned about.
Surge capacity remains a significant challenge. Emergency rooms every winter are flooded with patients who are sick with, as we saw this winter, influenza, norovirus, other kinds of infectious diseases, and you know, that capacity has not significantly changed.
And Dr. Frieden, is this something we're working on?
Absolutely.
Yes or no? Okay.
Absolutely, yes.
Thanks. If you can supplement and let me know what you're doing, that would be great. Dr. Goodman, I wanted to ask you, Dr. Cross had said that these new types of vaccines, the non-egg-based ones, are coming into production for next season. Is that right?
Well, they've both been licensed, and both manufacturers have stated they intend to produce the vaccine.
Okay, and what about some of these methods for increasing the effectiveness? Are those also coming online quickly?
There we're talking about they're in active research and development, but you know, even if a promising technology, you know, now being looked at in research looks good, that will be several years at least.
Okay, so that's several years,
Yeah.
but the other ones are coming on.
Oh yes,
now.
they've.
Now, what would happen if we had an avian flu pandemic or something? Would we be able to make vaccines more quickly than we can now?
Well, we are definitely better prepared in a number of ways.
Well, I'm sorry, I only have 5 minutes.
Okay.
So would we be able to make a large number of vaccines more quickly now with these new techniques, say, in the next couple of years?
Yes, between
Okay.
the new techniques and the increased capacity, yes. But
Okay.
we have a way to go.
Yeah, so now I want to ask you a question in that direction, which is, you know, next month we're supposed to have this sequester hit. And under the sequester, non-defense discretionary spending is going to be cut across the board by 5.2%. So I'm wondering, maybe Dr. Frieden, Dr. Cross, and Dr. Goodman, if you can talk to me about what this would do for operations at the FDA and CDC, both in terms of the research that's going on and also in terms of the preparedness. If we put a 5.2 cut immediately, what would this do to our ability to do all these preparations? Why don't we start with you, Dr. Frieden?
Well, the threats to our health in influenza are not reduced by 5%. So if we have fewer resources, we have to do everything we can to limit the harm that would do. And we are focusing on efficiencies. We've already eliminated substantial administrative costs, but more than 2/3 of our funding goes out to state and local health departments. And while we would try to protect the front lines, there would be no alternative but to reduce funding there.
So you'd have to reduce funding in the short term, but also I would assume you'd have to reduce funding as you're working towards increasing surge capacity and communication and interoperability and all of that, right?
With fewer resources, we would have less capacity to detect, respond, and develop better tools in the future.
What about your agency, Dr. Goodman?
Well, also, a substantial cut would have effects, and we certainly hope we're able to avoid that. It would affect, for example, the work we're doing to try to provide science and highly interactive review processes with development of these new technologies. It also affects FDA's user fee programs.
Right, I know.
And, so that would potentially have some effects on review process. But we're hoping this can be avoided.
And Dr. Cross? And maybe you can also talk to the NIH, since we don't have an NIH person here.
Well, I'm afraid I don't know how.
Okay.
DHS plans to implement any sequester and whether or not they're going to take money across the board or from particular pockets.
Okay. Thank you. Thank you, Mr. Chairman.
Thank you. Now recognize the Vice Chair of the Committee, Dr. Burgess of Texas.
Thank you, Mr. Chairman. I actually wasn't going to pursue this line of questioning, but since it has already been broached, I mean, any of us who are charged with running a small business or a large agency understand that from time to time we're going to have to make adjustments, and part of our role as leaders in whether it be a small business, a medical practice, or the CDC or the FDA, you got to be able to look at those things that you do within your agency and your organization and decide how to prioritize. And I just, a 5% cut, did I ever have to deal with that in my medical practice? You bet I did. And I had to go through every line of the budget and decide what is mission critical and what is not. I don't think that you all are any less capable of doing that. And certainly my goal in the past had been to get Department of Health and Human Services in here and talk about this last year. There seemed to be an unwillingness to do that. But just from where I sit, I think if you're not already doing that within your agencies and organizations, I would encourage you to do so, because this may very well be the reality. And the question is not will the sequester go through, but how many will you face over the next several years. So I just felt obligated to make that editorial statement. Again, it wasn't part of our hearing agenda today. It's too bad we haven't had anyone from HHS or Office of Management of the Budget come in and talk to us about their plans. And I think it certainly affects the governance of this committee, but it also affects your role and your lives on a daily basis. Now, it is unfortunate the National Institute of Health is not here, because Dr. Goodman, you were asked a question about how quickly can you do some of these things, and I'll just remember the experience of 2009 and the H1N1, and probably one of the scariest conference calls I've ever been on was in the middle of the NBA playoffs or whatever, I guess it was the NCAA playoffs, when these kids were coming back from Mexico with this novel influenza, and all of the things we had been warned about with H1, with this avian flu, H5N1, seemed to be coming true very quickly with this new strain. Now, it didn't turn out to be as devastating as that afternoon painted, but when young populations are predominantly being affected, there seemed to be the facility of transfer between human to human seemed to be well established, and the overwhelming immune response from a young person being very detrimental to their health. I mean, these were all things we'd been warned by Secretary Leavitt in the previous administration, and now they were coming true literally before our eyes. And yet, you all, the CDC, FDA, NIH, worked together, and by August, there were preparations for having this vaccination available for school teachers when school started the next month, and I thought that was an incredible accomplishment. I'm old enough to remember the last swine flu epidemic when the complications of the vaccination were worse than the illness. So I was gratified that all parts seemed to work together. I'm sure both of you were there at that time. And are you as good now as you were 4 years ago, or maybe even a little bit better now? Dr. Frieden will take your first.
I think we have continued to make progress. I do think a lot of the H1N1 pandemic experience is important to understand and learn from, as the GAO has summarized. You know, H1N1 was not a mild pandemic. About 60 million Americans got sick. More than 250,000 were hospitalized. More than 12,000 died, including more than 1,200 children. And the tragedies that you referred to earlier are heartbreaking. So we do everything we can to maximize use of the existing tools. There were more than 88 million doses of vaccine administered. We shipped vaccine to more than 70,000 sites and more than 300,000 shipments, generally the day after it was approved for shipping. And we think that both vaccination and treatment prevented around 1 million cases, roughly 15,000 hospitalizations, hundreds of deaths, and tens of millions of dollars of healthcare costs. So I do think there's a lot that went well in that, but there's always things that we can do better. And coming up with a vaccine that we can develop faster, get to market faster, extending our global surveillance. So no one expected a pandemic to emerge in North America. And we had been focusing in places where pandemics generally emerge in Asia. But we need to continue to develop our surveillance. There's so much we don't know about influenza around the world, what the seasonality is, what the predominant strains are, what the burden is. So we're working very closely with global partners around the world, and that's a very important part of protecting those countries and protecting ourselves, and then finally of strengthening the vaccine production systems.
Well, you know, of course, I'm about out of time, but this committee so often focuses on what didn't go right. I think from time to time we need to focus on what has gone right, and certainly the experience with H1N1, and I only look to improvement from that, but there were a lot of positives to take away from that experience. I'll yield back, Mr. Chairman.
I think the gentleman next is Mr. Green of Texas, recognized for 5 minutes.
Thank our panel and appreciate your patience. I think, and I talked earlier to Dr. Frieden, I think the flu epidemic that we had, and I watched your map, and being in Texas, at least for most of the Christmas holidays, I saw it happening there. But I get some of the questions I have for the panel is that, Dr. Frieden, how can public health providers and hospitals and patients do, what can we do to reduce the burden of the surge of the patients in our healthcare facilities during a bad flu season? I know our emergency rooms are stacked up, and you know, typically you can't do a whole lot about it except the vaccination, which gets into my other question, is that how can we actually do more than we're doing now to increase the percentage of the people who are getting their flu shot in September instead of waiting until the end of December or January?
Thank you very much. In terms of the surge, we have worked very closely with the Assistant Secretary for Preparedness and Response, and we've actually unified 2 different federally funded programs. One is the Preparedness Program, the Public Health Emergency Preparedness Program, and the second is the Hospital Preparedness Program. We now have a common application, a common system, and that makes it much easier for states and localities to use federal dollars to improve their ability to address surge capacity. We've also seen some creative approaches in different states where nurse call lines have been used through private insurers, through HMOs, through private doctors to talk to patients and for the routine patients to address their needs over the phone, perhaps prescribe medications for them if needed, tell them when they need to come in and when they don't need to come in. We also look at what we would do in a surge. It's bad enough if an emergency department is getting so many patients in, but if we have a very severe pandemic, some of the things that would be really problematic is the ability to provide emergency ventilation to breathe for patients who can't breathe for themselves. So through the Strategic National Stockpile, we've been increasing the availability of practical, effective respirators, and in fact, BARDA has come up with some new designs that should be on the market next year, which are very encouraging, low cost, high quality, easy to roll out, because this would be the lowest common denominator. This would be the bottleneck in an emergency, or one of them is being able to help people breathe for a period of time until they get better. In terms of increasing vaccination rates, I think what we've learned is make as many options as possible. So people can get vaccinated at school, at work, in pharmacies, but within the healthcare system, make it as automatic as possible. So that all too often people do go to the doctor, but they don't get the vaccination. The strongest risk factor for not being vaccinated is the doctor didn't offer it or recommend it or provide it. So we want to have automatic systems that increase vaccination rates.
Did the Affordable Care help on that in providing vaccinations more readily available?
One of the components is that for private insurers, it requires no co-payment for vaccination.
Okay. For either Dr. Frieden or Dr. Goodman, are we seeing resistance to Tamiflu?
We've seen virtually no Tamiflu resistance this season in the circulating strains.
Okay, outstanding. And again, the vaccination rate, I know, making it more available. And I know the controversy over even medical facilities saying we're going to require all our staff to have the influenza vaccination. In the private sector, I have companies that are doing that for their employees just because it makes good business sense. What are we seeing on that? Is there a lot of resistance from folks, even in the healthcare profession, saying we don't want to take the vaccine?
I think the biggest lesson is making it easy and accessible. So 80 to 90% of pharmacists, doctors, and nurses are getting vaccinated. But among allied health workers who may not be able to get vaccinated readily, and in nursing homes, which may not be doing as good a job at vaccinating, rates are 50% or lower.
And in nursing homes, you have, immune challenged patients, you have the elderly. It's almost like it'd be an incubator for it.
And nursing homes are particularly important to increase vaccination rates because there is some evidence that the residents of nursing homes do worse when the staff don't get vaccinated.
Okay. Well, thank you. Thank you, Mr. Chairman.
Thank the gentleman for yielding back. I now turn to the gentleman from Georgia, Dr. Gingrey.
Mr. Chairman, thank you. And witnesses, I apologize for coming in late, and I may end up asking you questions, obviously, that have already been asked. Just forgive me for that, and maybe if you repeat it, it'll stick in all of our brains better anyway. So, Dr. Frieden, I thought I would ask you the first question. According to your website, the CDC website, and in your written testimony, manufacturers have produced 145 million doses of flu vaccine this season and have distributed roughly 135 million. Which is almost 2 million more doses than last year. Why then do you think this season has been more severe despite the increase in the vaccine compliancy? That more folks are getting the flu vaccine, and I'm one. I didn't get the flu, thank goodness, but a lot of folks did.
This year's flu is H3N2, and seasons that are predominant for H3N2, the particular strain of flu, tend to be more severe. This year is quite predominant of H3N2. The last two seasons that happened were 2003-04 and 2007-08, and in both of those years they were severe flu seasons, particularly for the elderly.
Were they also H3N2?
They were. Mm-hmm. Why H3 is more severe, there are some interesting theories, but we do not know for certain. We do know that our vaccine efficacy, our early season estimate was about 60% overall. We also know that in previous years, generally the elderly tend to be less protected by the flu vaccine than the non-elderly, and the frail elderly even less so. We're only at around 40% overall vaccination rate, so being able to knock down influenza by vaccinating lots of people will probably require more vaccination than we're seeing, but a reduction of 60% in medically attended flu from vaccination also probably means a significant reduction in the spread of flu from those people who get vaccinated and don't.
And also, I guess, maybe decreased severity of the infection they do better than had they not had the shot, obviously. So, Dr. Goodman, I noticed that there was a lot of discussion about the process of cell-based or egg-based growth factor in vaccine production. I remember all that discussion back several years ago when we had that avian flu outbreak and the great concern there. How close are we to developing what you would call a universal flu vaccine?
Well, I think if you had asked me a couple of years ago, I would say we really can't be that optimistic. It's sort of a holy grail. I think there have been some scientific leads in the last 2 or 3 years that are a little more promising, and if some of these pan out, I mentioned a couple of possible technologies, directing a vaccine at conserved parts of the virus. It's possible that we could at least have some real leads and progress in this direction in the next 5 to 10 years, but it's not something that's just around the horizon. The good news is that the science that's out there to understand the immune system and understand the virus now is extraordinary, and we're all beginning to work to put that together. But we got a way to go.
Yeah. Dr. Goodman, thank you. And Dr. Cross, thank you. In your testimony, you stated that since 2005, Health and Human Services had awarded over $1 billion in contracts to 6 different manufacturers who are developing the cell-based technology to enhance our domestic vaccine production capacity, and I'm sure that that's a good thing. Yet only one of those manufacturers, Novartis, has received the FDA approval for vaccine production in the 2013-14 season. Is the FDA continuing to work with the 5 other manufacturers to continue its progress on switching to a faster and a more economic production model? I know I could have asked Dr. Goodman this exact same question, but if you will.
We understand that of the 6, there are, in addition to the 1 vaccine that has just been licensed, there are 2 more that are in later stages of clinical trials and that may be able to complete the process and be licensed in the next year or 2. I can't really predict how quickly they may come along. The other 3, they've ceased activities. I believe 2 of those contracts have already been canceled.
Who are the names, Dr. Cross or Dr. Goodman, if you know, that are working on this cell-based?
If that's something you can get back to the committee.
But, what I would say is those who are actively working on new influenza vaccine technologies, yes, we are working in a highly interactive way with them and with BARDA and HHS to help make that happen. The intent in some of these went through a process where, in essence, the most promising technologies and the things that have proceeded most fastest are the ones that are continuing to be funded, and others have dropped out of the process.
Thank you all. And Dr. Cross, I think the chairman is gonging me. He's got the shepherd's hook out. Mr. Chairman, thank you for your patience. I know I went over a bit. I yield back.
There is a table in my statement that has it.
Yeah.
That's part of the record, so we'll have that. But thank you, Dr. Gehring. Chair now recognizes the gentleman from New Mexico, and welcome to the committee, Mr. Luna, New Mexico.
Mr. Chairman, thank you very much. Really appreciate that. And to the witnesses, thank you for your testimony and for being here today. A different kind of a question. A critical piece of this infrastructure is the National Infrastructure Simulation and Analysis Center, or NISAC, which is a program that exists at both Los Alamos and Sandia National Laboratories. NISAC has the capability to model global spread of flu strains and has done so in the past. Have you engaged the National Security Science Laboratories to use their predictive and modeling capabilities such as NISAC to understand both the spread of influenza as well as to devise strategies for interdiction?
We have had some interactions with them. I would have to get back to you with the details of those, but certainly the advanced computing is quite important, including in some of the new diagnostic and genomic experiences. What we're able to do now is to sequence entire genomes in just a few hours. And to put that together is like putting together a jigsaw puzzle with more than 1 million pieces. So the computing power needed for that is quite important. And that's an area where we've collaborated with the national labs and where we see potential for future growth.
Thank you. Anyone else? I'd really encourage that we try to work with our departments, agencies, to encourage them to closely work with the national labs in this endeavor. There's a huge benefit, and we saw that the last time that we had a pandemic breakout. My home is also state to a large population of Native Americans, like other communities across the country, as well as a diverse population. What are your agencies doing to ensure that these communities are being reached out to and included in your priorities when it comes to pandemic flu preparations, and is there active consultation?
In fact, just last week we had our Tribal Consultation Advisory Committee meeting at CDC in Atlanta. We work very closely with Native American groups. As you know, during the 2009 pandemic, we identified Native Americans as one group that was more severely impacted by influenza for reasons that we don't fully understand. We have for many years had a very productive relationship with the tribes on immunization issues, and vaccine uptake tends to be high in many of the tribes. In fact, we've collaborated with tribal leaders and tribal members to do some very important research on things like pneumococcal disease in the tribes, and that research has benefited not only the tribes but the population throughout the United States and throughout the world. So there's a good collaboration and good consultation. We've explored ways to reach out and increase vaccination rates. We've also worked closely with the Indian Health Service on detection, response, and vaccination, not only in influenza but other infectious and non-infectious diseases. For example, we recently identified spread in New Mexico of the Rocky Mountain spotted fever from one reservation to another through the dog tick, and we're working with private industry and tribal leaders to control that disease with some efficacy and impact. So we have a real focus on working effectively with higher risk groups, including American Indians, Native Americans, Alaskan natives.
I appreciate that very much and look forward to learning more about that. One of the questions that's been asked over and over is, why aren't people taking the vaccine? We know that education is important as well. Are there a lot of effort being put behind addressing mistruths or misconceptions associated with taking, getting the flu shot, and what impacts to each of you might sequestration have associated to scalebacks that we've seen with cease disease surveillance activities or some of the work that takes place from an education perspective?
In terms of your first question, the increasing uptake, we think, is going to require efforts on many fronts, making the work, making vaccine easier for people to take, making it part of the workflow of healthcare professionals. Too many people do see a doctor during flu season but don't get vaccinated, increasing the options for vaccination. And sunlight is the best disinfectant, so providing information. There are people who have some reluctance about vaccination, and just providing the information openly we find to be the best way. We're completely open. All of the adverse events that people report after vaccination are all reported on our web. We provide information openly so that if there are any concerns, they can be addressed. And as I noted earlier, we have made substantial administrative savings at CDC in recent years through travel, conferences, leases, Blackberries, printers, computers, and we have been able to reduce administrative expenses. But at this point, further reductions will unfortunately translate into reductions to support that we provide for tribes, for states, for localities, for disease prevention and control, as well as for core activities.
Thank you. Thank you, Chairman. I yield back.
Thank you, gentlemen, for yield back. And now recognize another new member to the subcommittee, the gentleman from Mississippi, Mr. Harper.
Thank you, Mr. Chairman, and thank each of you for being here, and appreciate the work you do. It's extremely important, and we certainly want to make sure that you're equipped to do that job in an effective way. I'm just, I hadn't planned on touching on this, but since it has come up and continues to come up about the sequestration and the potential 5.2% cut. I just want to make sure that, and Dr. Cross, you gave an answer that was, I'll leave you alone because you said you didn't know, so you can take a little break on this one. But Dr. Frieden, Dr. Goodman, you both indicated that it could impact actual programs too that go out. But it would seem to me that I want to make sure that you're not saying how that would be done or how you would operate within that, but it would seem to me if you've got 94.8% of your budget, that you can work it out internally and administratively where that wouldn't have an impact on patient care or on the folks that you would be reaching. And I want to make sure that I'm not reading something into your statements as to what you said, because I know built into a budget you have open positions that may not need to be filled. You have administrative costs. It may be travel. It may be advertising. It may be things that you've built in that you wanted to do that perhaps you can trim back but won't have a direct impact if this does indeed kick in. And Dr. Frieden, I'll let you go, and then Dr. Goodman next.
We do take very seriously being diligent stewards of the funds entrusted to us. And over the past few years, as we have seen some reductions in recent years, we have gotten out of leases. We have reduced conferences and consulting contracts. We've actually, at a flat budget level, sent more money out to the field. So we feel that we've done, I can't say absolutely everything we can do, but we've certainly done a great deal of what we can do.
But it's fair to say, Dr. Frieden, I know we have limited time here, but it's fair to say you would make every effort you could and within the organization to make sure that it didn't have that impact, if at all possible. That would be a fair statement, wouldn't it?
We would certainly do everything we could to mitigate the negative health consequences.
Dr. Goodman.
Yeah, I think I have a very similar response in that, we have tried to tighten things up and be efficient stewards of our resources and have our resources really have the public health benefit that you and the American people want us to provide. So we are doing that. If we were faced with a cut, it would have some consequences, but certainly we are going to manage that in the most responsible way that we can.
Fair enough. Thank you, Dr. Goodman, Dr. Frieden, for those answers. We're obviously, when we're concerned about the influenza situation, the virus, and obviously supply and distribution are key. And so this would be for each of you, if I could get your response. Are you continuing to work with manufacturers to ensure an adequate domestic supply chain of medical countermeasures, and secondly, to improve the distribution of those medical countermeasures during a pandemic or a moderate or severe seasonal flu epidemic like this year?
Absolutely, and I'll let Dr. Goodman discuss more about the work with the manufacturers. We work with them by providing seed strains, and what our laboratories have been able to do is to optimize those seed strains so that they're strains that grow faster and that may be more effective when used in vaccines. So we're hoping to see kind of useful and important tweaks without huge breakthroughs yet in the flu vaccination. We also work through the Strategic National Stockpile in an emergency to provide vaccines, countermeasures, and medications. What we found in the pandemic was that the vaccinations through the Vaccines for Children program could be scaled up enormously. So we were able to provide more than 300,000 shipments, more than 80 million doses very quickly, very effectively. We've been working to improve our ability to provide medications. Those are available, but there isn't a system to get them out there. And one of the things that we learned about emergencies is it's best to have an everyday system that can be scaled up. So we're looking at some models of doing that even more effectively in the future.
Thank you, Dr. Frieden. Dr. Goodman.
Yes, absolutely. We work extremely intensively with the manufacturers, and during flu season, it's almost a daily contact of our staff scientists with them, solving problems, working on issues, trying to get vaccine out quickly. I would also say through the medical countermeasure enterprise across HHS, DOD, we are working together, and now FDA is involved at the earliest stages when the requirement for a countermeasure is defined, when requests for information or contract go out to industry. And the idea there is to avoid surprises, spend as much effort as we can to increase the likelihood of success. So I think we're really helping keep that investment a very efficient and effective one.
Thank you, Dr. Goodman. Dr. Cross, I'm not meaning to ignore you, but I'm out of time, so I yield back.
I thank the gentleman. I now recognize the gentlelady from Florida who is returning to the committee, Ms. Castor. Welcome.
Well, thank you very much, Chairman Murphy, especially for calling this very important hearing. And I want to thank our panel and experts for doing everything in your power to help Americans ward off the flu. But I noticed before I get to my flu question, you know, when we're talking about the sequester, I think it's very important for everyone to remember we've already slashed the budget of the CDC and the FDA. So when you're talking about additional draconian sequester cuts, you're not just asking the agency to be efficient, because the agencies have been efficient and have cut. What you're doing is you're cutting into their core missions that affects the productivity of Americans, our ability to ward off foodborne illnesses, SARS outbreaks. Think about the challenges with the flu. These things don't happen by magic. We have a responsibility to the American public and businesses to get them vaccinated, to get them all the tools they need to ward off disease. And I think it's just wishful thinking to say, well, can you accept more budget cuts, more budget cuts, more budget cuts, and not expect the core missions of these very important public health agencies to remain intact. So back to the flu. In my home state of Florida, the nursing home population is critical. And I notice the CDC has said that 90% of deaths from the flu come from people who are age 65 and older. This year, the flu has hit this population particularly hard. I'm hearing more about how we're faring this season among that population, how effective our response has been, and what we're doing to protect older Americans. So, Dr. Frieden, can you talk about the impact of this season's flu on older Americans?
This year is an H3 year, and as in prior H3 years, it's more severe among the elderly. The hospitalization rate of laboratory-confirmed flu, which is something that I provided in a graphic to the committee, is about twice or more what it has been in recent years. So overall, this is a worse than average flu season and a particularly severe one for the elderly. Some of the things that we can do to reduce the severity is vaccination, not only of seniors, but of people around seniors, so that they're a lot less likely to get infected by someone else. And then prompt treatment with a medication such as Tamiflu, which, particularly if given in the first 48 hours, will reduce the likelihood of progression to severe disease. Also, in nursing homes, vaccination of healthcare workers is particularly important. There is some evidence that nursing homes that have lower vaccination rates among their staff have much worse outcomes in flu season.
And many of these long-term care facilities, they just don't vaccinate their workforce like some hospitals do, or cancer treatment centers. Why is that, and what can we do to promote greater vaccination rates among long-term care employees?
We have seen steady progress in the proportion of healthcare workers getting vaccinated. It's currently slightly over 60%. It was in the mid-40s for many years. So we've seen progress, and particularly among doctors, nurses, and pharmacists, we see rates of 80 to 90%. But working with nursing homes to make sure that vaccination is easy, provided, free, on work time for their employees are all examples of things that are best practices and have been shown to be associated with higher rates. There are certainly nursing homes that do an excellent job at this, and so what we'd like to do is see those best practices spread.
Okay, in addition to increasing vaccination rates for long-term care workers and many others, one of the keys to reducing the severity of seasonal flu is making sure that there's a good match between the strains in the vaccine and the strains of flu that are in circulation. Dr. Goodman, how well matched were the strains in this year's vaccine to what we saw circulating?
Fortunately, the strains are very well matched this year, so that isn't an issue. The issue here is the severity of this virus, the number of unvaccinated people, and then, as we've discussed, that we would love to have a vaccine that's even more effective, especially for the elderly.
So we had good matches this year. We didn't have any shortages in vaccines, even regionally or in certain areas.
Well, we had good matches. There are times, what we always see is when it's sort of like whitewashing the fence. When there's bad flu around, people want the flu vaccine, and there's a lot of demand. So we have seen, and CDC's helped manage situations where people might have transient difficulty locating vaccine, but there is still vaccine available, and people can still get vaccinated.
Well, I thank you all very much, and it's very important that we support our public health agencies so we can continue to minimize life-threatening illnesses and protect the productivity of American workers and businesses and protect the health of our families. So thank you very much. I yield back.
Thank the gentlelady for yielding back. And I'll recognize another new member of the committee, gentleman from Texas, Mr. Olson, who is recognized for 5 minutes.
I thank the chair, and welcome to the witnesses. Thank you all for your time and your expertise. Just a little bit back about myself. The district I represent is Texas 22. It's a suburban Houston district. That is ground zero for pandemic flu outbreaks. I mean, we're about to be the third largest city in America. And I want to apologize to my colleagues from Illinois, but Chicago's going to be number 4 pretty quickly. And we have the largest foreign tonnage port in America. That means traffic's coming from Asia, from Africa, from Europe, right there, the port of Houston. We've got this huge transportation, land transportation infrastructure from Latin America. NAFTA, trucks, all the traffic coming across from Mexico, right down Highway 59, which goes right through my district, which is now I-69. And while it's true that my hometown's minor league baseball team is called the Skeeters, after mosquitoes, it's not true that the mosquito is the national bird of Texas. It's the mockingbird. But my point is, we have a lot of mosquitoes, we've got a lot of rodents, a lot of birds, all sorts of transmission paths, in addition to human beings. And I want to follow up on some of the comments that Dr. Burgess and my colleague Gene Green made about the outbreak we had, the H1N1 outbreak in 2009. That summer, you all know we had a big outbreak there across the country, but Houston was number 2, I think, of national outbreaks. And, I mean, 11 schools shut down. I mean, parents were terrified what was happening with their kids. And as you know, with these pandemic outbreaks, there are basically 4 steps we have to take care of. First, we have to, diagnose it. The CDC has to come through and say, this is the virus, this is what it is, this is how we fix it. We have to make the vaccine. We have to get the vaccine manufactured out there, and we have to get it to the people and have to deliver it, get it to the local people to deliver it to the people who are infected by disease. And it was pretty clear that outbreak in 2009, CDC got behind pretty quickly with all the tests that are being required. These people are getting samples, all sent to you guys. I think you fixed that some, Mr. Dr. Frieden, by having some local regional centers set up just to address the sort of explosion of tests. I also know we've had big problems with delivery. I mean, the Texas Children's Hospital had to set up basically a drive-thru in a parking garage because so many people wanted to come get those vaccines. So my question is that big picture, and this one's for you, Dr. Friedman, and for you, Dr. Goodman. What keeps you up at night? I mean, what is your biggest concern? What can we fix here? What is your biggest concern with our country dealing with these pandemic flu outbreaks?
So of all of the naturally occurring infectious diseases, it is influenza that causes us to lose the most sleep because of its potential to kill. During the 1918 pandemic, more than 50 million people around the world died. And influenza can spread rapidly and unpredictably. One of the most predictable things about influenza is that it's unpredictable. So in order to do a better job of protecting Americans, we need to strengthen our global surveillance system so that we can detect new strains of influenza soon after they arise anywhere in the world. And we've worked very closely with governments around the world as well as the World Health Organization to strengthen laboratories. In fact, during the H1N1 pandemic, within literally days of the discovery of the virus, we had already produced a real-time PCR assay that we distributed ultimately to more than 100 countries around the world so we could track what was happening with it. But that virus was probably circulating for a couple of months before it was identified. So it emphasizes that if any part of the world doesn't have good monitoring systems, we could miss whether it's influenza or another health threat emerging and not be able to respond as quickly, because if we can stop it or mitigate it where it emerges, that's better for that part of the world and that's better for us as well.
We're working with some other institutions across America to do that. For example, the University of Texas Medical Branch in Galveston has this Bio4 laboratory. I went and toured that thing. That's space-age technology. You have this, these suits they dress you up in because they're dealing with some pretty serious diseases. They said exactly what you're saying, that our biggest problem is we can find something somewhere in the world here. If we get the virus, we can probably have it done in 24 to 48 hours, they say. We can figure out what the vaccine's going to be. Then obviously got to manufacture. But I encourage you to work with them and all those different labs out there because they're great assets for us. Dr. Goodman, what keeps you up at night, sir?
Well, I think we're all sharing those same concerns of a new or different infectious agent where we don't have a great vaccine or great therapies that could occur either naturally, and that's the history of the world, or potentially, deliberately. So we, I agree totally with Dr. Frieden. We need to have strong surveillance, and things really have improved in that area too, and the molecular tools have improved. I think we also need the next piece, which is the ability to develop and produce medical countermeasures, vaccines, drugs, much more quickly than we currently can. Normal drug development and vaccine development is a multi-year process. So among the things we're working with through our enterprise, HHS, DOD, et cetera, is new technologies to have a much more rapid, flexible response so that we can get vaccines much more quickly, so that we can develop treatments. And also, there's been considerable progress, like we described in our testimony, in increasing our nation's capacity and being sure we have the domestic capacity in the industrial infrastructure to work with the government and respond to a public health crisis. So again, we're better off, but we've got to harness new science to have much faster responses and be able to face a new threat. And this isn't just flu, it protects us from terrorism too. So all of these, we're taking a multi-hazard approach where everything we do, whether it's surveillance or response, can be used because we can't predict what will emerge. So we want tools that will work for whatever will emerge.
Thank you, Dr. Cross. You can sleep well at night, ma'am. That's the end of my questions. I do have some questions for the record, sir, about adjuvanted vaccines that are being used in Europe, sort of developing new technologies for vaccines. But thank you very much.
The gentleman yields back. The gentleman's time's expired, and we now recognize the gentleman from Virginia, Mr. Griffith, for 5 minutes.
Thank you, Mr. Chairman. On these new vaccines that are being worked on, and it doesn't matter to me who answers the question or if people have different opinions. I'm just curious. We know about the allergy problem for certain people with the eggs, but with the new vaccines that are done with cells, have there been any allergic reactions that we know of? Have there been any tests to see if folks that have other types of allergies are reacting to those vaccines?
Well, the good news is that, first of all, many people with egg allergies have safely taken the egg-based vaccines because they're fairly pure and they don't have tons of, egg protein in them. But there are people who have had severe allergic reactions to the current vaccines, extremely rare. For those who have them due to eggs, both the new recently approved vaccines should provide a potential advantage. One is produced in cells, so there's no exposure to eggs, and the other is produced in cells, but using insect cells through recombinant technology. So these are very pure vaccines and don't contain egg protein. So I think that will be a help. I don't know, I want to get back to you for the record, but I'm not aware of any significant problem with allergic reactions to either of the new vaccines other than what we would normally expect with any flu vaccine.
All right, thank you. With that, Mr. Chairman, if I can yield the remainder of my time to Dr. Burgess, I would do so.
I thank the gentleman for yielding. Dr. Goodman and Dr. Frieden, at the end of 2005, an omnibus appropriations bill was passed. It had the defense appropriations in it. A lot of the pandemic preparedness was contained therein. And again, going back to my opening statement, there was discussion about the universal vaccine. Dr. Frieden, you've talked about the difficulty with the surface proteins, how they're ever changing. I think, Dr. Goodman, you even mentioned developing a vaccine to the stock or the housekeeping proteins that are contained within the coat. How close are we? This was one of the promises in 2005. It's 7 years ago.
Yeah. Well, I would, nature is very tricky, and as I said, this is a very crafty virus, so I would really hesitate to predict. But as I said, I think we see some promising science. I think the earliest we could begin to see something where we could maybe examine whether it has clinical benefit might be within 5 to 10 years. So, and that's if we see some of these technologies really take root. And I am excited about them, but I know my colleagues at NIH, who also do this and fund this for a living, feel the same way. There's some exciting prospects, but it's got a way to go. Certainly, your support and the investments being made will help us get there faster, we hope. We have wonderful vaccines against all kinds of infectious diseases. We're protecting children against pneumonia, against measles, against polio, et cetera. This is not for lack of trying. This is because this is a hard scientific problem. As I said, the human immune system does not respond very well to influenza, and when it does, the influenza virus is very tricky at getting away from that response.
Well, is a universal vaccine still a worthwhile goal?
Still a goal?
A universal vaccine, is that still
a worthwhile goal?
I'm asking you, is it a worthwhile goal?
Absolutely, absolutely. I mean, can you imagine if we could have a world where we didn't have influenza pandemics?
You can just imagine, though, the frustration. In 2005, we're told we're 3 to 5 years away. You're telling me now we're 7 to 10 years away, and it's 7 years later.
I don't think I would have said that, but and I'm not sure who did. But I think, we see new technology, and we're always very hopeful. And it's kind of the way you go in science is to be optimistic and pursue the best leads. But one of the things we also certainly have seen is, this is a very challenging scientific problem.
Well, let me ask you this. On challenging scientific problems. I mean, so we got a good match this year, so we're grateful for that. But still, the prevalence of infections in those over the age of 65 is still higher. So what is the difficulty there in conferring the advantage to the individual over 65?
One of the challenges with influenza is that our own natural immunity isn't particularly good. And vaccines don't usually do better than we do in nature in defending against infections. The elderly, particularly the frail elderly, who are more susceptible to severe flu, don't in the past respond very well to the flu vaccine. There is a new product on the market that uses a triple dose of the antigen. We are told by the manufacturer that by the end of next flu season we'll be able to get a sense of whether that makes a difference or not. But influenza is one of the things that's quite challenging. 90% or more of the deaths in most years tend to be among the elderly. So one of the things that we can do is vaccinate more people around them to tamp down the spread of flu. A second is to treat promptly, because there is evidence that if you treat someone within the first 48 hours, they're less likely to end up in the intensive care unit, and it may have other benefits as well in reducing spread.
Very good. I yield back.
Mr. Chairman, I ask unanimous consent for 30 seconds to follow up on that question.
Without objection.
So the follow-up question, Dr. Goodman, is, and by the way, it was the CDC apparently in this 2005 hearing that said it was 3 to 5, and it wasn't Dr. Frieden that said that. Dr. Goodman, this universal vaccine, 5 to 10 years that you said, if we wanted to speed that up, is that a resource question or is it a science question, or both?
I think at this point it's mostly a science question, to be honest.
Thank you. The Chair recognizes now the gentleman from Ohio, Mr. Johnson.
Well, thank you, Mr. Chairman. And first of all, let me say what a privilege and an honor it is to now be a part of the Oversight and Investigation Subcommittee. I look forward to serving with all of our colleagues as we address the many important issues that face us. And with that, let me say I received my flu vaccine this year, and I have not gotten sick yet. So for those involved, thank you very much. I'm very much appreciative. I represent a district in Ohio that is extremely rural. It takes me 6.5 hours to drive from one end to the other. There are many places throughout my district where my constituents have to drive 30, 40 miles to get to a physician or to get to a pharmacy or to get to a flu shot if they were to have a reaction. So this is, and especially given your testimony already, the impacts that it's having on our seniors, and I have a lot of seniors down in that area. So, Dr. Goodman, can you explain a little bit more about the testing process in place to verify the safety, the sterility, and the effectiveness of the vaccine?
So, you know, as part of each manufacturer's approval or license, they're required to do numerous tests throughout the vaccine manufacturing. In multiple stages, they have to monitor production. And then when they create these large-scale bulk amounts of vaccine, those are all tested for their potency, their sterility, to be sure there's no contaminants, toxins, et cetera. In addition, they submit samples of that to FDA, which our laboratories test. And then once all those tests are okay, they fill the vaccines into the final containers or the syringes, or for the live vaccine flu mist, the nasal spray. And they also test, where appropriate, those final formulations. So there's very extensive testing and quality control, you know, among the most intense, I would say, for a medical product. The other thing that we do that's very important is working closely with CDC. We monitor the safety of all licensed vaccines very carefully, and this is particularly true of influenza vaccine. We monitor for major side effects in real time using, for example, the CMS database, and this is actually some of the most novel science done in looking for adverse events. And we're working to stand up a much broader system that uses healthcare settings that have electronic medical records to monitor vaccine safety, called PRISM, and we plan to have that up and running next year. So they are very intensively monitored, and I would say one of the ways our country was able to do, you know, I think we all did a good job working together, but we were able to do a good job with vaccine uptake in the 2009 pandemic, is that we were able to track safety in real time, and when the public or certain people raised concerns about the safety of vaccine, to be able to share the data which showed it was safe. Conversely, if there ever were, God forbid, to be a problem, we think it's important to have systems in place to detect it rapidly.
Sure. Do you think that the development time for the vaccine, because it seems to get longer and longer each year as the virus mutates, is that harming our ability to react to a potentially strong flu season?
You know, the manufacturing of flu vaccine is complicated, and as Dr. Frieden said, flu is unpredictable. We also say flu vaccine manufacturing is unpredictable. Sometimes the viruses grow better than other years. Sometimes they yield more of the vaccine material than other years, so it can be a challenge. This year went relatively smoothly. We've had other years where vaccine is delayed. Typically, it's about the 6-month process beginning to end. We're all working to speed that up. There are parts the virus controls, like how it grows, and that's what got us in the pandemic. The virus just wouldn't grow. But there are parts that we can help control better. We recently approved rapid sterility tests that, instead of taking 2 weeks, take 3 to 5 days. We're working with CDC and others to make better potency tests, which now take weeks to develop, and we think we can shorten that. So we're working to shorten the portion of the time that manufacturers and the regulatory agencies are responsible for. But we are at the end left with the whim of the virus, which is why some of these new technologies like cell-based and recombinant may provide us with a safety valve if problems occur.
One quick question before my time expires, which is almost here. Again, given my rural district, are there, I'm sure there must be scientific formulas to determine the distribution of the vaccine to make sure that you've got them in the right places so the population can get to them. I'm sure there's a different methodology for a big city like Columbus or Cleveland or Los Angeles than for rural Appalachia, Ohio.
We work closely with public and private sectors to make sure that vaccine is available, other than some spot shortages it generally was this year, and using community providers, senior centers, pharmacies, and other places. Any opportunity to provide vaccination, many states allow pharmacists, nurses, nurse practitioners to vaccinate under a doctor's order or supervision, can increase access in rural and other areas.
Thank you, Mr. Chairman. I yield back.
I think the gentleman also forgot to mention a welcome to the committee to the gentleman who represents the East Coast of Ohio. Appreciate it.
Yeah, the very long East Coast.
Long East Coast. Now I recognize another new member to our subcommittee, the gentlelady from North Carolina and a nurse. Ms. Elmer is recognized for 5 minutes.
Great. Thank you, Mr. Chairman, and again to our panel. Thank you for being here and answering our questions. I happen to be the lucky recipient of the district that has the Novartis, the new, beautiful, gorgeous Novartis facility in Holly Springs, North Carolina. And so my questioning is along that line of what they're going to be able to do. My first question, Dr. Frieden, for you is, with considering now the advancements and how exciting it is that we're taking the path of new technologies in vaccinations, how is it, and how can you describe to us the demanding or expanding the demand for facilities like this, manufacturing, can be a help in this area? Because we're looking for solutions moving forward. How can this facility be a step in that right direction?
Well, as you know, the cell-based manufacturing offers advantages, cutting a couple of months out of the time frame, not using eggs, and having one more option. And one of the things that has been encouraging in recent years is the increased number of options: intradermal vaccination, intranasal vaccination, high-dose vaccination for seniors. So the more options we have, I think the more uptake we'll have. But we'd like to see a substantial increase in uptake of influenza vaccination, and that's going to require continued effort. We do really well with childhood vaccination in this country through the Vaccines for Children program, where we provide about half of all the vaccines that are used. Not only do we have very high rates, but we've eliminated racial and ethnic disparities in childhood vaccination. But we don't do nearly as well for adolescents and adults. And part of that is putting in place systems in our health care that make it routine, that put, frankly, nurses in charge rather than doctors to make sure that something gets done regularly and routinely.
I'm all about that. Now, little competition doesn't hurt. Along that line, and I know Dr. Goodman touched on this as well, what is the advantage, if you will, speaking to the cell-based vaccine versus the egg? Of course, we all know about egg allergies, but I know you had mentioned, the rapid, rate that we can be manufacturing and growing. So can you just touch on a couple of those as well?
So not being reliant on eggs is quite important, because you might have a shortage of eggs in the case of a pandemic. So that's an important advance. As Dr. Goodman mentioned, the egg allergy issue is less of an issue, because we find that true egg allergy is extremely rare, and we have not generally seen problems. In fact, we've clarified our recommendations in the past year to say really it has to have been a real severe anaphylactic allergy, because we found many people saying, well, I don't like eggs, so I'm not going to have the flu vaccine.
Or fear factor.
Right.
Dr. Goodman, I did want to ask, in this particular facility, the Novartis facility, it's licensed now for the pandemic vaccine, but not yet licensed for the seasonal. Is that correct?
I have to be careful about public information versus their protected information. But it is licensed for certain operations with respect to flu vaccine. It is not finally licensed for production of seasonal vaccine. And I know Novartis is working with our staff to get it going and get it on board, and that's their plan.
How long, a facility like this, how long would something like this take? I mean, and there again, I'll just say hypothetically for other facilities that may have taken that plan.
Yeah, it sort of depends on the issues encountered, and I know that there is really highly interactive engagement, and everybody's goal is to get it going as soon as possible, and and things have been going well. So
good. And what I'll say is any help that we can be in that effort, I'll be more than...
No, as I said, the relations between FDA and with the manufacturers in this area have been tremendous and very collaborative. Yeah.
Excellent. Well, thank you so much.
Sure.
Thank all of you so much for your input, and I yield back.
I thank the gentlelady for yielding back. We've covered all of the members here. I just want to cover a couple of housekeeping.
The gentleman yield for 1 second.
Yes.
Mr. Chairman, I just want to congratulate you on your first hearing in O&I, and I want to congratulate all of the members for the committee that we've shown. This is an important issue, and I really appreciate the bipartisan cooperation, and I think you're setting the tone for a really good 113th Congress. I just wanted to compliment you.
I thank the gentlelady, and the same compliments go to the ranking member and all the members here. And to those who testified today, we know this is a serious topic, and I know our hearts go out to all those families across America who lost loved ones during this flu epidemic. But the information you're providing, the research you're providing, and the recommendations for the future are going to be critically important to save more lives next year, and so we're looking forward to that. A couple of housekeeping matters. I do ask unanimous consent that the written opening statements of members will be introduced into the record without objection. The documents will be entered into the record. Again, thank the witness for coming today and for the testimony of members for their devotion to this hearing. The committee rules provide that members have 10 days to submit additional questions for the record and to the witnesses. This was my first hearing as chairman of the subcommittee, and I appreciate all the constructive and bipartisan dialogue that we've had. When problems or issues arise that impact our public health, I'm committed to finding out how we can effectively address them, and the FDA is going to continue to play a critical role in this regard. Dr. Goodman, I do have a request, if you would do this for us, to take back to Commissioner Hamburg. As you know, the committee has been investigating the deadly outbreak of fungal meningitis linked to compound drugs since October. Almost 2 weeks ago, this committee sent Dr. Hamburg a letter and notified her that unless all responsive documents are produced by February 25th, the committee will move to compel their production. We've not received any documents since the day we sent the letter. Dr. Goodman, could you please, on behalf of this committee, tell the Commissioner that we expect the FDA's cooperation, and the only way for HHS to avoid receiving a subpoena in the meningitis investigation is to produce all the documents we requested by the February 25th deadline. I thank you for taking that message back to the FDA, Commissioner, and with that, again, I thank all the members. This hearing is adjourned.